Imagine a patient just, bursting through the ER doors. They're gasping for air, they're turning pale, and their chest is just heaving in absolute panic.
Right, it's a terrifying scene.
Yeah, and to anyone watching, it looks like a textbook case of lung failure. But if the emergency room physician treats that patient for lung failure, they might actually kill them.
Because their lungs are perfectly fine.
Exactly. Their heart is failing, and they're basically drowning from the inside out.
It really is one of the most high-stakes diagnostic puzzles in medicine. I mean, you have two massive interconnected systems, the pulmonary and the cardiovascular. And when one collapses, it mimics the other almost perfectly.
Cracking that exact puzzle is our mission today.
Welcome to the deep dive, everyone. We are digging into a huge stack of clinical protocols, respiratory therapy lectures, and critical care physiology.
We really want to uncover the hidden mechanics of the human respiratory system. Right, to figure out how medical professionals decode those really subtle clues of a respiratory crisis in real time. And by the end of this deep dive, you won't just understand the brilliant engineering of your own body. You'll have, profound agency over how you view health emergencies.
It really changes your perspective.
It totally does. Okay, let's unpack this. Because before we can figure out why the system breaks down in the ER, we have to understand the physical mechanics of just a single breath.
Which is more complex than it feels.
Yeah, like I always pictured the lungs actively sucking in air, but biologically, the lungs themselves are completely passive tissue.
Right. They're essentially just highly elastic bags.
Yeah.
The actual mechanics of breathing rely entirely on creating a vacuum.
A vacuum.
Yeah, so the diaphragm, which sits right below the lungs, it contracts and flattens downward. And at the same time, the external intercostal muscles pull your rib cage up and out.
Which expands the total volume of the chest cavity?
Exactly. It's Boyle's law in action. Volume and pressure are inversely related.
So by expanding the chest, you create this negative pressure chamber. The intrathoracic pressure drops below the atmospheric pressure outside your body, and the air just rushes in to fill the void. I mean, it's basically like pulling the plunger back on a syringe.
That's a perfect analogy. The physical pressure gradient does all the heavy lifting. But what's fascinating here is the gauntlet that atmospheric air has to run before it ever reaches those delicate alveolar tissues.
Right, the body's defense system.
Exactly. The moment air enters the nasal cavity, it hits the nasal conchae. These are these bony, scroll-like structures that literally force the air into a turbulent spin.
Oh, to slow it down.
Right. That turbulence slows the air down significantly, forcing it to interact with the highly vascular mucosal lining. So this rapid heat exchange warms and humidifies the air.
Which the lungs need.
They absolutely need it. And while that's happening, enzymes like lysozymes are actively breaking down bacterial cell walls on contact.
Wow. And then it has to navigate that tricky intersection of the respiratory and digestive tracts.
The pharynx, yes.
Yeah, so you have the uvula swinging upward to seal off the nasopharynx, so nothing you swallow goes up into your nose. And then the epiglottis slamming down over the glottis so nothing goes into the airway.
It's brilliantly simple. The physical act of swallowing pulls the entire larynx upward, which forces that cartilage flap to fold over the opening, directing food cleanly down the esophagus.
But if that mechanism fails, it brings up this very weird anatomical quirk from our sources. I like to call it the peanut rule.
The peanut rule.
Right. If you accidentally inhale a peanut, it is almost entirely guaranteed to end up in your right lung.
It's true.
Because the trachea splits into the right and left main stem bronchi, but the right bronchus is wider, it's shorter, and it sits at a much steeper, more vertical angle than the left. So gravity and geometry just essentially funnel inhaled foreign bodies straight down the right pipe.
It's a notorious anatomical trap, especially for pediatric patients or, anyone with compromised swallowing reflexes.
So the peanut goes right. Good to know.
Right. Now, assuming the air is actually clean, it travels down into the microscopic lower respiratory tract. And this is where the defenses shift from anatomical physical barriers to an active cellular clearing mechanism.
Down at the microscopic level.
Yeah. The lining of these lower airways is composed of ciliated columnar cells and goblet cells.
So goblet cells are the ones that make the mucus, right?
Exactly. Yep. They constantly secrete this highly viscous mucus to trap microscopic debris. And then the cilia, which are these millions of tiny hair-like projections, they beat in this synchronized rhythmic wave.
Ah, the mucociliary escalator.
You got it. It's literally a constant upward-moving conveyor belt. It actively sweeps that debris-laden mucus against gravity. up out of the lower lungs to the pharynx, where it's either subconsciously swallowed or coughed out.
That is wild.
And deeper down in the terminal bronchioles, club cells take over. They secrete a protective protein lining and basically act as stem cells to regenerate any damaged airway epithelium.
So, okay, the air finally reaches the end of the line, which are the alveoli. And we have, what, roughly 500 million of these microscopic air sacs?
Give or take, yes.
But thinking about the physics here, something doesn't really add up. You have 500 million tiny spherical structures, and they're coated in fluid.
Right.
And water molecules have incredibly high surface tension. They form hydrogen bonds and just pull aggressively toward each other. So why don't these millions of wet microscopic balloons just snap shut and collapse every single time you exhale?
That is such an important question because the physical forces are absolutely trying to collapse the lung.
Just constantly squeezing.
Yes. If it were just water lining the alveoli, the surface tension would be so immense that the muscles of your chest couldn't generate enough negative pressure to pull them open again. You'd literally suffocate.
Oh, wow.
But the body produces this highly specialized complex of lipids and proteins called surfactant.
Which acts kind of like a biological detergent, right?
Exactly like a detergent. It's an amphipathic molecule, meaning one end loves water and the other end repels it. It's secreted by these specialized cells called type 2 pneumocytes.
And what does it actually do to the water?
Well, the surfactant molecules essentially wedge themselves between the water molecules, physically disrupting those hydrogen bonds and drastically reducing the surface tension. It literally holds the alveoli propped open.
Which completely explains the tragedy of respiratory distress syndrome in premature infants.
Yes, RDS.
They're born before those type 2 pneumocytes fully mature and start producing surfactant, right? So their alveoli just collapse simply because of unchecked surface tension. It's a massive mechanical failure born entirely out of this tiny microscopic chemical deficit.
It is. Without surfactant, the compliance of the lung just plummets. It becomes incredibly stiff, and the infant basically exhausts all their energy just trying to force the tissue open with every breath.
Okay, so we've managed to tunnel this clean, humidified air all the way down into 500 million nice, stable alveoli. But air just sitting in a sac is completely useless to a dying patient. The real bottleneck is how that oxygen physically crosses over into the bloodstream.
Which brings us to the ventilation to perfusion ratio, the VQ ratio.
The holy grail of respiratory physiology.
It really is. For efficient gas exchange, ventilation, which is the V representing the air reaching the alveoli, must perfectly match perfusion.
And perfusion is the Q.
Yes, Q represents the capillary blood flow passing by those alveoli. So normal alveolar ventilation is roughly 4 liters of air per minute. And normal cardiac output through the pulmonary bed is about 5 liters of blood per minute.
Which gives us a VQ ratio of 0.8, the biological sweet spot.
0.8 represents optimal efficiency. But what's fascinating here is that the lungs don't operate at a neat 0.8 ratio universally. The mechanics at the apex, the top of the lungs, are wildly different from the base at the bottom.
Wait, hold on. Gravity pulls the blood down to the base, so perfusion is obviously highest at the bottom. But wouldn't the air naturally rise, making the top of the lungs better ventilated?
You'd think so, but think about the physical weight of the lung tissue itself.
Okay.
The lungs are literally hanging, suspended inside the pleural cavity. Because gravity pulls that massive spongy tissue downward, it stretches the alveoli at the very top of the lung.
Oh, I see it now. Because the tissue is hanging, those apical alveoli at the top are already pulled open and stretched tight, just resting there.
Exactly.
It's like a balloon that's already fully inflated. It isn't very compliant, so it can't really stretch much more when you take a breath.
Perfect analogy.
But the basal alveoli at the bottom are sort of squished under the physical weight of the lung above them. They're compressed, meaning they have a massive amount of room to expand when that negative pressure hits.
Yes. The basal alveoli are highly compliant. So when you inhale, the vast majority of that fresh air physically flows to the base of the lungs, precisely where gravity has pooled the vast majority of the blood.
So the base of your lungs does all the heavy lifting for both ventilation and perfusion.
It really does. But, of course, the math breaks down in disease states, creating dead space and shunts.
Right, let's talk about that.
So when ventilation exceeds perfusion, meaning you have plenty of air but no blood to actually pick up the oxygen, the VQ ratio shoots above 0.8. This is what we call dead space.
Okay.
Now, we all have anatomical dead space, which is just the air sitting in the conducting airways where gas exchange can't physically happen. It correlates to roughly 1 milliliter per pound of ideal body weight.
So a 150-pound person has about 150 milliliters of air just sitting in the pipes.
Exactly. But alveolar dead space is a crisis.
Like a clot.
Yes, like a pulmonary embolism.
Yeah.
If a massive blood clot lodges in the pulmonary artery, the air fills the alveoli perfectly, but the blood flow stops.
Yeah.
All that oxygen is trapped in an empty station.
And on the flip side, if blood is flowing normally but the airway is blocked, the VQ ratio drops below 0.8. That is a shunt. But wait, if an entire lobe of the lung is blocked by, say, a massive mucus plug or pneumonia, isn't the heart just wasting vital energy pumping blood to an empty area? Like, how does the body not just bleed out its oxygen reserves, sending blood to total useless tissue?
It employs a really brilliant evolutionary defense mechanism called paradoxical vasoconstriction.
Paradoxical.
Yes. In every other tissue in your body, if oxygen levels drop, the blood vessels dilate. They open wide to pull in as much oxygenated blood as possible. But the lungs have the exact opposite job. They don't consume the oxygen, they supply it.
Oh, so they react differently.
Exactly. If an alveolus is blocked and becomes hypoxic, the localized pulmonary capillaries instantly constrict. The lung intentionally pinches off the blood supply to the suffocating alveolus, actively diverting that blood flow toward healthy regions of the lung that actually have oxygen to give.
That is incredibly smart routing. But from a clinical standpoint, how does a doctor actually measure the efficiency of this exchange? I mean, you can look at a patient's oxygen saturation, but that doesn't tell you how hard the system is working to get it there, right?
Right. They look at the A gradient. The capital A stands for the partial pressure of oxygen inside the alveolus, and the lowercase a is the partial pressure of oxygen inside the arterial blood.
So it measures the gap between the two.
Exactly. It measures the physical efficiency of oxygen diffusing across the alveolar capillary membrane.
So if that membrane gets damaged, the gradient widens.
Correct.
Take pulmonary fibrosis, for example. Chronic inflammation leaves the delicate membrane scarred and severely thickened. Normally, a red blood cell spends about, 0.75 seconds traveling past an alveolus in the pulmonary capillary?
Yes, roughly 3/4 of a second.
Which is plenty of time for oxygen to diffuse across a healthy, thin membrane. At rest, even a patient with fibrosis might maintain normal oxygen levels because the blood is moving slowly enough to eventually cross that thick scar tissue. But what happens if they try to run up a flight of stairs?
Well, their cardiac output spikes, the heart pumps faster, and that red blood cell accelerates, whipping past the alveolus in roughly 0.25 seconds.
Oh, wow, that's fast.
Too fast. Because the barrier is severely thickened, the oxygen physically cannot diffuse across the scar tissue fast enough before the red blood cell is gone. The patient's arterial oxygen levels...
But confusing them is lethal. And to make it worse, 20 to 30% of patients with severe COPD also have underlying heart failure.
It is an absolute diagnostic minefield. Let's look at the underlying mechanics of the two opponents here. Chronic obstructive pulmonary disease, or COPD, is characterized by chronic, irreversible air trapping.
And it comes in two main forms, right?
Yes. Emphysema physically destroys the alveolar walls, basically obliterating the elastic recoil of the lung and creating massive pockets of dead space. Then you have chronic bronchitis, which involves severe chronic inflammation and hyperplasia of the mucus-secreting glands.
Creating thick plugs that block the airways.
Exactly.
Here's where it gets really interesting, because COPD is a slow, relentless disease the body attempts to compensate over years, leading to these wild physiological adaptations. In critical care, they talk about the 50-50 club.
Ah, yes, the 50-50 club.
These are end-stage COPD patients who walk around every single day with an arterial oxygen pressure of 50 and a carbon dioxide pressure of 50. Normal oxygen is up in the 80 to 100 range, and normal CO2 should be well below 45. Right.
A perfectly healthy person suddenly dropped to those numbers would likely be unconscious or in cardiac arrest. But a COPD patient is sitting there reading a magazine.
The human body is remarkably adaptable. But contrast that chronic air trapping with the fluid overload of heart failure. In left-sided heart failure, the left ventricle is simply too weak to efficiently pump blood out into the systemic circulation.
So it backs up.
Exactly. Because the pump is failing, the blood backs up into the pulmonary veins, drastically increasing the hydrostatic pressure inside the pulmonary capillaries. That sheer physical pressure forces blood plasma out of the vessels and straight into the alveoli.
Pulmonary edema.
Yes. The patient is suffocating under their own fluids. They're coughing up pink, frothy sputum and suffering from severe orthopnea, which is the inability to breathe when lying flat because the fluid literally spreads out across the lungs.
Man. And what if the failure is on the right side of the heart? Right-sided heart failure causes a systemic backup. The right ventricle can't push blood effectively into the lungs, so the pressure backs up into the vena cava and the peripheral venous system.
Meaning the whole body swells.
Exactly. The fluid gets forced into the peripheral tissues. You see massive pitting edema in the legs, fluid pooling in the abdomen known as ascites, and pronounced jugular vein distension in the neck. You also see rapid, massive weight gain, frequently over 3 pounds in a single day, which is purely retained water.
And the really brutal reality is that severe COPD can actually cause right-sided heart failure directly. It's called cor pulmonale, right?
Yes, cor pulmonale.
The lung tissue is so scarred and the pulmonary vessels are so constricted from chronic hypoxia that it creates severe pulmonary hypertension. The right ventricle has to pump against a brick wall, eventually hypertrophies, and just fails entirely.
It's a vicious cycle.
Which brings up the most terrifying trap in emergency medicine. If a patient is turning blue in front of you, the immediate instinct is to throw a non-rebreather mask on them and blast them with 100% oxygen. Why is that the exact wrong move for a COPD patient?
It all comes down to the body's respiratory drive. In a healthy nervous system, breathing is dictated by the central chemoreceptors in the medulla. They monitor carbon dioxide and pH levels.
Okay, so CO2.
Right. When CO2 builds up and makes your blood acidic, the brain forces you to take a breath to blow it off. We breathe to remove CO2, not to gain oxygen.
Wait, really?
Yes, but think about the 50-50 club. Chronic COPD patients have retained toxic levels of CO2 for so long that their central chemoreceptors have become completely desensitized.
The CO2 alarm system is basically broken, so what forces them to keep breathing at all?
They switch to a backup system called the hypoxic drive. This is monitored by peripheral chemoreceptors in the carotid bodies and the aortic arch. And these receptors only monitor oxygen. The patient's brain only sends the signal to breathe because it senses a state of constant, mild hypoxia.
Oh, no. So if a clinician blasts that patient with high-flow oxygen,
the arterial oxygen levels suddenly spike. The peripheral chemoreceptors detect the high oxygen, assume the respiratory crisis is completely resolved, and immediately shut down the drive to breathe.
the patient stops ventilating.
Yes, they stop breathing, retain even more CO2, become lethargic, and slip into respiratory arrest.
You literally trigger an arrest by giving them the one thing they seem to need most.
Exactly.
That's why the clinical protocols dictate a very tight target for COPD patients. Strictly maintain their oxygen saturation between 88 and 92%. You have to keep them just hypoxic enough that their brain remembers it still needs to work.
Right. You are intentionally keeping them on the edge to maintain that fragile neurological drive.
So if you can't just throw oxygen at the problem and hope for the best, how does an ER team decode the symptoms and lock in the right diagnosis under that kind of pressure?
They start by gathering mechanical evidence. Put a stethoscope to that gasping patient's chest. What does fluid actually sound like versus trapped air? The acoustics of the chest tell a very clear story.
Let's run through them. Wheezes are the classic indicator of obstruction, right? High-pitched, musical whistling sounds, usually most prominent on expiration.
Right.
It physically means the air is being violently squeezed through a narrowed, inflamed bronchiole, like air shrieking out of the pinched neck of a balloon. That points heavily toward asthma or COPD.
Spot on. And if the airway is partially blocked by thick, viscous mucus, you'll hear raunchy. These are lower-pitched, rumbling, rattling sounds in the larger airways.
Sort of a gurgle?
Basically. Because it's a physical blockage of fluid in the macrostructures, raunchy will often dramatically change or clear up entirely if you just ask the patient to cough.
But crackles are the true alarm bell for heart failure.
Absolutely. Crackles, or riles, are the physical acoustic snap of deflated, fluid-logged alveoli suddenly popping open under negative pressure.
What do they sound like?
Well, fine crackles sound like rolling strands of hair right next to your ear. Coarse crackles are much louder, sounding like ripping Velcro or bubbling fluid. When you auscultate bilateral crackles at the bases of the lungs, you are hearing acute pulmonary edema. You are listening to heart failure.
You might also hear a pleural friction rub, which sounds exactly like two dry pieces of leather or pebbles grinding together.
Right, from inflammation.
Yeah, it happens when the lubricating fluid between the pleural membranes diminishes, causing the lung tissue to literally scrape against the chest wall. And if you hear stridor, which is a harsh, high-pitched screeching from the throat during inspiration, you aren't dealing with the lower lungs at all.
Stridor is terrifying.
It means the upper airway is rapidly closing from an obstruction or anaphylactic swelling. That is an immediate drop-everything airway emergency.
Auscultation is critical, definitely. But physical observation is just as vital, particularly in pediatrics. Infants can't articulate their dyspnea. You have to look at the mechanical work of breathing.
Right, look for the struggle.
Because pediatric chest walls are highly compliant and cartilaginous. Severe airway obstruction forces their diaphragm to contract so violently that the extreme negative pressure physically sucks the skin and muscles inward around the skeletal structure.
You literally see their chest caving in.
Yes.
Supraclavicular retractions above the collarbone, intercostal retractions pulling the skin tightly between the ribs, and subcostal retractions beneath the rib cage. You'll see their head bobbing with every inspiration, and they will instinctively grunt on exhalation.
The grunting is key.
They're prematurely closing their glottis to trap air and generate intrinsic positive pressure, desperately trying to keep their alveoli stented open.
Right. Now, to definitively split the diagnosis between COPD and heart failure in adults, emergency protocols heavily rely on objective diagnostics.
Yeah.
They immediately pull blood for a BNP assay.
Brain natriuretic peptide.
Right. It's a hormone secreted by the ventricles of the heart when they are stretched by volume overload and extreme pressure. A highly elevated BNP definitively points to acute decompensated heart failure. A normal BNP in a dyspneic patient strongly indicates a primary pulmonary issue like COPD.
They also utilize point-of-care lung ultrasound. The physics of the ultrasound waves interacting with a fluid-thickened interlobular septum create these distinct vertical comet tail artifacts.
B-lines.
Yeah, B-lines. Seeing multiple B-lines spreading across the monitor is a rapid, definitive confirmation of pulmonary edema.
And the chest X-ray provides a massive visual contrast too. Because X-rays pass easily through gas, air shows up black, while fluid and dense tissue show up white.
So a severe COPD exacerbation yields massive, hyperinflated, deeply black lung fields.
Exactly. The sheer volume of trapped air physically pushes the diaphragm down until it's completely flattened.
And for heart failure.
A heart failure patient's X-ray will reveal prominent white, cloudy infiltrates radiating from the hilum and distinct horizontal lines at the periphery called curly B lines,
Which represent fluid.
pure fluid tracking through the lung interstitium. You also see a massive reduction in the peak expiratory flow rate. A COPD patient might only generate 26% of their predicted expiratory flow because their airways collapse under forced expiration. Whereas a heart failure patient, despite the fluid, can often maintain around 49% of their predicted flow.
Once that diagnostic split is confirmed, the treatment paths violently diverge. If the X-ray shows curly B lines and the BNP is through the roof, the patient is in heart failure. The problem is volume overload.
Yes.
The gold standard treatment revolves around aggressive loop diuretics. The clinical shorthand I learned is drugs ending in "ide," like furosemide, make the body dried.
That's a great mnemonic.
They forcefully inhibit sodium reabsorption in the kidneys, prompting massive diuresis to aggressively offload the fluid volume and drop the pulmonary capillary pressure.
You aggressively dry out the lungs. But if the diagnosis is a COPD exacerbation, diuretics are practically useless. The pathology isn't fluid volume. It is bronchoconstriction and trapped carbon dioxide.
So you pivot.
The treatment pivots to short-acting bronchodilators, like albuterol, to physically relax the smooth muscle of the airway, anticholinergics like ipratropium to reduce mucus secretion, and high-dose systemic corticosteroids to aggressively crush the airway inflammation.
And crucially, the use of non-invasive positive pressure ventilation like BiPAP.
BiPAP is a lifesaver.
Instead of just giving oxygen, BiPAP physically drives pressurized air down the trachea during inspiration and maintains a baseline positive pressure during exhalation to stent the airways open. It physically splints the bronchiole open so the trapped toxic CO2 can finally escape.
And we must emphasize the absolute contraindication in severe COPD.
Oh, this is important.
The administration of central nervous system depressants. Giving a COPD patient in respiratory distress a dose of an opioid or a benzodiazepine to treat their anxiety will fatally suppress their fragile hypoxic drive.
So what does this all mean? We have navigated an incredibly complex physiological landscape today. We started with the sheer physics of Boyle's law, utilizing negative pressure to pull atmospheric air into the body. We examined the relentless microscopic sweeping of the mucociliary escalator and the chemical brilliance of surfactant-defeating surface tension. We explored the delicate mathematical balance of the VQ ratio and ultimately dissected the chaotic, high-stakes clinical chess match of differentiating the fluid overload of acute heart failure from the suffocating air trapping of end-stage COPD.
The mechanics are vastly intricate, but understanding them strips away the panic of the unknown.
And that is exactly why you should care about this. This isn't abstract biology. Whether you are observing an infant's chest for intercostal retractions, monitoring your own peripheral oxygen saturation, or standing in an emergency room fiercely advocating for a parent who is too hypoxic to speak for themselves, grasping these underlying mechanics gives you profound agency over medical crises.
It really allows you to decipher the clinical language and ask the critical questions when seconds matter most. But before we conclude, I want to pivot and offer a final, highly provocative thought drawn from the hospice care protocols we reviewed.
Okay, let's hear it.
Everything we have discussed so far has been framed entirely around reversing pathology and fixing the mechanics to save a life.
But the goals fundamentally change at the end of life.
Drastically. Terminal respiratory decline, particularly in end-stage congestive heart failure, rarely resembles the steep, precipitous drop of other terminal illnesses. It's a grueling staircase decline.
What do you mean by staircase?
Patients suffer severe exacerbations, stabilize slightly lower than their previous baseline, and plateau, only to exacerbate again months later. They frequently transition onto and off of hospice care multiple times. But what is truly profound is how the entire philosophy of treatment inverts at the very end.
How so?
We spent this deep dive cementing the absolute clinical rule that administering an opioid like morphine to a respiratory patient in the ER is strictly forbidden because it suppresses their drive to breathe.
Right, you just said it's a fatal mistake.
Yet, when a patient enters final end-of-life hospice care suffering from refractory untreatable dyspnea, administering targeted doses of liquid morphine becomes the absolute gold standard of care.
Wait, why intentionally suppress the system you spent years trying to keep running?
Because at that ultimate stage, the clinical objective completely shifts. The goal is no longer to mechanically fix the failing alveolar gas exchange or increase cardiac output. The goal shifts entirely to altering the brain's neurological perception of air hunger.
Ah.
The morphine effectively blunts the central nervous system's terrifying panic response to systemic hypoxia. It dilates the pulmonary vasculature to slightly ease the cardiac workload, but more importantly, it allows the patient's body to finally genuinely relax.
It frees them from the raw terror of suffocating.
Exactly. It's a stunning, beautiful paradigm shift in medical philosophy, intentionally sacrificing mechanical respiratory drive for the profound sake of human comfort and absolute peace.
Wow, that completely recontextualizes how you look at the entire respiratory journey. From the very first involuntary negative pressure breath rushing in to fill the void, right down to the profound peace of the very last.
It is the full spectrum of physiology and care.
We'll leave you to ponder that complex shift in perspective. Thanks for joining us on this deep dive.